To get
Hi
tonight.
everyone, just getting started. Thank you so much.
And you?
Oh, yeah, buy a ticket. All right, great.
Hello and welcome to the Science and Society Network seminar. I would like to start by acknowledging the traditional owners, the Wurundjeri people of the Kulin Nations, who are the traditional custodians of the lands in which we're meeting today, and I'd like to acknowledge their elders past, present and emerging. My name is Emma Kowal. I'm Professor of Anthropology here at Deakin and one of the co-conveners of the Science and Society Network. And we are really excited to have this talk, which is just the night before the Easter weekend. So we're very, very glad of people who have made it into Deakin Downtown, and we know there's many more watching online, on YouTube live, and I'm sure afterwards as well. So please do, after or during the talk, feel free on the YouTube chat to introduce yourself, say hello. Career Traits, our amazing coordinator, is there as your host on the chat, and do feel free to put questions in the chat as we go along. We'll have a lot of time for questions, and of course here in real life from the floor. But I should mention why we're here and what we're here to talk about, which is very exciting. So today we have Catherine Bennett, who doesn't need a lot of introduction, but I will still introduce her, of course. She is Distinguished Professor and Foundation Chair in Epidemiology here at Deakin University. One of her many, many roles, and the one that's particularly relevant to what she'll be talking about today, is her role as one of the three-person independent panel that led the Australian Government COVID Response inquiry. And most Australians know her from the media. She's become a media star, basically. Let's not mince words here. And just a public intellectual and a public health communicator in a way that, very, very few people in Australia and in the world have. And her role in moderating such a difficult space of public communication. And I think going into the Easter weekend, and things are just so back to normal, everyone's going down the coast or, hiding their Easter eggs, and it's really easy to just completely forget that, 5 years ago, it was so different, and we had a couple of really, really extraordinary years when the world completely changed. And Catherine was there to really help us feel a little bit more in control of a very crazy situation, and now has really led this inquiry that is going to hopefully, if the recommendations are heeded, will put us in much better stead for the next pandemic, which is, I think most of us understand, it's now inevitable that eventually there will be another one. So just to give a tiny bit of background on her background, she's had experience in government, in leadership in government, and as a infectious disease epidemiologist and public health researcher. Before she came to Deakin, she was Director of Population Health Practice at the University of Melbourne, and then she led the School of Health and Social Development for a long time, for 9 years, till just before the pandemic, which was lucky for us Australians that she was able to focus on COVID. And her research, as well as this really very substantial piece both of research and public policy, she also works on community transmission of infectious disease and antibiotic resistance and community-led research. So I will pass over to Catherine, who is agreed, this is a special request for her to talk to us about specifically working across disciplines in the COVID inquiry, but I'm sure she will extrapolate that to many other aspects of her work. And we will have plenty of time for questions, so please do note down what you want to discuss more. And thank you so much, Catherine, and so excited for this talk.
Thank you, Emma. And thank you for the invitation. When Emma talked to me about this, I thought this could be something I could really enjoy, pulling this whole experience together in a way that actually reflects some of the other things that are kind of core to my career and my purpose, I think. So I'll just see if that's sharing now. So this will basically use the inquiry as a bit of a case study, really, talking about the notion of traversing disciplines. It's been a feature of my career, and I'll run through a bit of that as well, but also how that relates to government structures and provenance of policy, which again has been a bit of a recurring theme. Too many things fall between policy domains. So I'll begin by acknowledging the Wurundjeri people of the Kulin Nation for the area where we meet here today, and elders past, present and emerging, and in the custodians of all the lands where people are joining us from today. But I also wanted to recognise and respect the holistic concept of health, because it's very much the theme I'm talking to today as well. First Nations people recognise that health encompasses physical, social, emotional, cultural and spiritual well-being for both individuals and communities. And that's very much the way we were mindfully approaching the inquiry. So I'm going to give you my tortured career path in 5 minutes, just to give you a bit of background for the time that led into my academic roles. And it is a path of great diversity, but there are commonalities which I want to draw from it, because it's the things that both I think come to what I see my purpose and my commitments being, but also the things that have shaped me as part of that. So my undergraduate training was actually microbiology and genetics, but I kind of quickly moved into population genetics and physical anthropology or biological anthropology. And that was many reasons. One was that I was sort of naturally okay at biostatistics. I'd wanted to stay in zoology because I could draw. I had very broad interests. I'd read a lot, but I could draw. And they suggested that might actually not be the main thing that should determine which career path you take, but I should stay with genetics because that would be a better support for micro. And microbiology was then, at that time, my passion. And it was partly my passion because I had done a series of practical classes called epidemiology. Before epidemiology was a career, let alone a thing in terms of degree structures or career structures. And I loved it so much, I thought I'll specialise in microbiology. They kept me interested in genetics because of its relevance to microbiology. And of course, I ended up really moving into the whole genetic space for my honours in particular, and then subsequently. Coming off the back of the honours then, I was approached about becoming the state physical anthropologist for Victoria. So it's a thing when you take on some training in a very, very bespoke area that all my colleagues at university said, "What are you doing?" They were all doing lab science training because that's where all the jobs were. And it's true, there were no jobs in physical anthropology. This was the first time the government had appointed a state physical anthropologist. But as it happened, I was the only person with training. So that became an opportunity to both exercise the skills that I'd acquired, but also to really understand the importance of this work, that what it could bring to Indigenous communities, particularly at a time where things were very fraught in terms of large skeletal collections in museums, many of them of no known origin, so people couldn't determine who the custodians were. And also an interest in the communities themselves and what we could learn about past cultures from the skeletons. So I did focus my PhD, particularly looking at postcranial skeleton, because there wasn't much work had been done in that space. From a forensic perspective, much less from a societal or a cultural or a mortuary practices perspective. So, and throughout this time, I was now engaging with anthropologists, archaeologists, linguists, sociologists, a whole range of people, but most importantly, Aboriginal communities, and sitting with them under a passion fruit palm up on the banks of the Murray River and hearing their stories and hearing how they'd experienced science, for example, and how my work was perceived and how we might work together. So very, very informative times for me. I had to eat during my PhD. I went off and thought I'd better get some paid work, and an opportunity came up with the Royal Children's Hospital in a newly formed Centre for Clinical Epidemiology, Biostatistics. And again, being someone with kind of relevant skills, though I was working with dead people, not live people, but I had the biostatistics and so on, and I had the interest. And I went along to the interview and they said, have you thought about becoming an epidemiologist? And I said, well, thinking about it, I suspect I'm a paleo-epidemiologist, which was a bit of a laugh at the meeting. 5 years later, paleo-epidemiology was a thing. Anyway, but a lot of my skills were transferable. But again, it was about engaging with football clubs, with families, monitoring for the football injury study, how our children interacted with sports and the safety of what was then the Vic Kick, now the AusKick program. So again, very much a consultative piece of work. So I finished my PhD, and off the back of that was appointed onto the National Skeletal Provenancing Project based at the South Australian Museum. I had the privilege of being technically the first scientist ever appointed to the anthropology department at the University of South Australia. At a very contentious time, actually, when there was a lot going on with Hindmarsh Island Commission, and it showed how difficult interrelations could be between amongst Indigenous communities, but also with anthropologists who were also very divided in the way that they were engaged over the issues of Hindmarsh Island. I'm not going to go into that today, but it was a fascinating time and a terrible time in many ways for all those involved. From there, I followed in the footsteps of Frank Fenner, actually. He's the only other person that I know of that went from the University of South Australia to the ANU. And this is what I was told when I applied for the Master of Applied EPI program. So having completed my PhD, I knew I had a lot of the skills that I was already using in epidemiological research, but I didn't have the kind of public aspect of it. So there was an opportunity to apply for this very competitive program. I didn't think I'd get in. It's usually doctors, medical doctors, and I thought I'm a bit weird and I'm working in a museum, what will they make of that? But in fact, they were very interested, and the projects I worked on were diverse. It was about lead poisoning in community, Kosovo refugee intake, foodborne outbreaks, and again, so much work with community and across sectors in government as well, particularly for the Kosovo refugee intake. So I started to really learn about the complexities of government and policy and how that impacted in public health crises. And so just to keep moving into that space, I then finished that work and had an opportunity to apply to be one of the public health coordinators for the Sydney Olympics, as you would. Interesting time, had a lovely business card that had the Olympic rings on it. It's a privilege to have that. And people would look at it and they go, oh, and then they go, oh, because they realised you only had a job for a year and a bit. But anyway, it was a microcosm for all of government. So all the various agencies involved in how we worked with them. And so this was, that was chemical, biological, radiological incident preparation. It was disease surveillance. It was communicable disease prevention. It was a whole range of things that we had to work on together. And then came back to academia, and we've had a slight kind of quick run through that as well. But all those things that were important about having translatable research, answering questions people were interested in and working with people to understand what questions to ask, let alone how to do the analysis and answer, was the theme of my career. And just to acknowledge Bernie Marshall in the room today, who I blame for bringing me from Melbourne to Deakin, but who is one of the great people also working in public health, in health promotion in particular, who's taught me a lot in my career as well. But then, as soon as I'd sort of landed at the University of Melbourne, I was called up by the Vice-Chancellor's office because they'd realised they still held ancestral remains in the anatomy department and needed to negotiate with government. So when they went to government said, you do know who you've got in your university, Catherine Bennett. And they went, oh, who's she? I was a level B, lecturer in epidemiology. Anyway, so they called me up and asked me if I would assist the university in managing this return to communities through Museums Victoria. And I said, if the university is committed to making this an exemplary handover, I'm your man. I'll work with you. So I kept this kind of dual relationship with the two sort of informative parts of my career, the application of biostatistics in quite, I think, important areas of human interest and solutions to some pretty classic problems that communities were dealing with. So community engagement, stakeholder engagement more generally were very strong themes. So too is the fact that a lot of this was uncharted territory. When I became the state physical anthropologist, I rather, with some trepidation, walked into the laboratory down in South Melbourne at the time with the Victoria Archaeological Survey, kind of waiting for someone to give me something that would show me what the job would be. And someone eventually came down late in the first day and handed me a folder and they said, this is the protocol for what you do to respond when we get a call out from the forensics, from police. And I thought, oh, thank God, there's something to work on, because I wasn't finding much in the lab at all. And they said, you'll want to rewrite this. And that was just one of those sort of clunk moments in your life, you know, where you think, what am I doing here? But in fact, within a month, I'd rewritten it and had something that the protocol that worked for me, and I think then set up a process. But it was also this transdisciplinary nature of the work. And it had to be. You had to be able to work with other people. You had to find common language, common ground. You had to recognise they all had different inputs. And that was across professions, it was across government departments, it was across different sectors and community. And that was a really key part of the work. And I'll come back to that as a theme today. But it also came with some vulnerability, particularly when you're early in your career. And I found myself using the term out on a limb quite a lot as time went on. And more recently, when asked to give presentations on leadership after the COVID work, not the inquiry, but the work itself, you know, I use this image to kind of just talk through some of the things about being out on a limb, sticking to the evidence, but knowing that not only everyone wouldn't agree with you ever, but in fact, very few people were out there speaking loudly who were close to the evidence. It was really the people who had very extreme divisive views. We should never have lockdown. We should always have lockdown. There weren't many people talking in the middle, and that really did make you feel quite isolated. But it was only when I was preparing this presentation, and I pulled out that picture just to kind of talk a little bit on that I remembered a picture my uncle prepared for me when I was a child. And we had a family do, and he said to me, I want you to jump off this step like you're leaping for your life. And I don't know if you can see, but I've actually got my tongue out. I'm trying so hard to do what he said and do such a good job of emulating a really meaningful leap. And then he did the collage and the hand painting and so on to make a picture for me for my birthday or whatever followed. And I just thought, that's a lovely way. I'm going to use my own out on a limb or leap of faith, which is, I think, partly what was guiding me through my career, or leap of commitment, maybe. So we come then to the inquiry. So a lot of water's passed under the bridge. I've done more work in the research space and teaching at Deakin. And then the inquiry followed 4 years of intense involvement in the public space with COVID, or three years at the time. And when they approached me, I'd already been thinking about possibly writing a book. And the phrase that kept coming to mind was in the heat of a moment. Because I think people would always sit back and judge policy decisions without realising what it would have been like in those first weeks in particular, having to make those decisions based on very little evidence. But actually, sitting through the conversations over 2024 with all the various stakeholders from the inquiry, I realised it was something else for the policymakers. It was what they would define as fear. It was looking at what was happening overseas and actually not knowing what would happen here. And even later when we'd taken our own path, not knowing how opening up what that would mean for us. It wasn't going to be like 2020 in other countries. We worked really hard to make it not like that. But what would it look like? How would we respond to the virus across the community? But even more importantly in some ways was the duration of this, and this sense that as soon as you learn and feel confident that you know something, it changes, or you've got a new problem that you don't fully understand. It was this relentless uncertainty. So keep all of that in mind as I now fly through a helicopter view of the inquiry and some of the things, the ways we approached that piece of work. But remembering that it was built on the generosity of people, whether they were frontline health workers, members of the Aboriginal community who'd really worked hard to support their communities in difficult times, very senior politicians at state and federal level. So the inquiry panel was led by Robin Cruck on the top left, extraordinary person, great knowledge of public administration, but also had been Secretary for New South Wales Health for a number of years, so brought great experience and networks to the role. And Angela Jackson, an economist, but who had completed her PhD working with people with disability, which was a really important other aspect to all of this. We produced a report that was 900 pages long. Now, this is a year's piece of work, but we felt it was really important to both document what had happened so that that wasn't lost, and we could see things being already lost from memory, if not from records. And we also produced a summary report that we thought that's the one people will read. But we took this as an opportunity to approach them very differently. The first one was talking about particular aspects, whether it was leadership, the economy, aged care, vaccination, and each has a clear chapter for people to go to who have interest in those areas. The second one, though, was built around some pillars that we thought were really important for capturing kind of a higher order understanding of what we need to have in place before a pandemic and how we need to approach pandemic preparedness and response. We also had a team of about 35 at its peak working with us from the COVID-19 task force. So these were some of the graduates in the government scheme, but also people who'd had experience working across all the various departments that were relevant. So Treasury, social services, health. So people that came in with an understanding of the cultures, the processes, the infrastructure, all the things that we needed to be thinking about in relation to this whole of government inquiry. So at the time we were approached about this, we were told, think about it. Don't tell me yes or no whether you'll do this now. Just consider it and we'll tell you a bit more about what we're looking for. And they would send information out to us and want some clearances, you know, before they'd talk to you any further, they had to make sure that you had no police record and so on. So you'd go through those things and all the emails were titled possible member of panel. So it was all possible member of panel. So we're kind of waiting for something to happen because this was sort of going on. And then we had short notice that there was going to be a media conference with, it was actually the Treasurer and the Minister for Health that were going to announce the inquiry. And I thought, well, great, now things will happen and we'll be told eventually, you know, they'll make the decision about the panel. So 29 minutes before the press conference was about to start, I receive an email from the Prime Minister's office and it's an email from the Prime Minister, not even thanking me for it, but just basically letting me know that I was doing this work. So I didn't actually technically ever get asked, which was quite interesting. But they also sent out the terms of reference at that press conference, and there was immediate kind of reaction to that. And perhaps the most obvious one was around the fact that the scope didn't include unilateral decisions made at state and territory level. Now, there are a lot of people, particularly in Victoria, who wanted this to be the day of reckoning for Dan Andrews, so they were really annoyed. But there were people across the country who said, no, it can't be that. It's got to be all of Australia, even though it had been set up explicitly as the Australian Government response. But the panel had decided, you know, in our preliminary conversations before we'd been told we were doing this, but that they had to be included because they were all things that were done in unison. They affected the way people registered what was being done at a Australian government level, because if it was playing out differently in different states, or there was conflict between states or between federal and jurisdiction level governments, all of that mattered and it impacted on the Australian government perception of the Australian government response. So we were always going to be including them, just not the individual decision about whether we should have locked down when there was that particular outbreak at the Holiday Inn, for example. The other thing that was big at the time was the sense that it should have been a royal commission. And they wanted a royal commission because that would compel people to come in front of the panel. So it was a royal commission. I wouldn't be on the panel, there'd be lawyers, but it would also be usually public, live streamed. People use the term in Canberra circus, and people would be repeating all the things they said at the time and defending the decisions that they made. And that wasn't going to give us what we thought the Australian public deserved. We wanted the lessons. We wanted the wisdom, what had happened when people thought through what had happened. As it turned out, and what they did, more importantly, as it turned out, everybody participated bar one senior official. Everybody else joined in And there were only 2 of those who joined in, maybe 3, who I'd say behaved like they might have in front of a commission panel. The rest, I was really struck by how thoughtful they were and how different they were to the person that we were seeing at the time, if they were decision makers. But the input was really quite amazing. So I said yes, because it was an inquiry and because we believed that we had to capture this, and we also needed to document what happened, but capture the wisdom and try and see what we needed to do to be better prepared next time. I also did it because epidemiology itself was so central in all of this. It had become very public, but it was also weaponised and politicised. And so people who were not epidemiologists were suddenly calling themselves that, or people who were epidemiologists were suddenly infectious disease epidemiologists. But people were also just playing with the data and using it to support things that they thought or they believed in. And just to personalise it, I was also involved in being named by politicians who would say, well, Greg Hunt on one occasion said, if Catherine Bennett's worried about this, we should all be worried about it. But then people would think you were nailed to the coalition mast, and other people would be slamming you because you were too liberal or you were too Labor or progressive. So if you stayed with the evidence, which was often somewhere in the middle, you have to lock down, but only as you need to, and be really aware of the impacts of that. You had the people who thought you should never lock down and the people who thought you should always lock down, slamming you from both sides. So it was the balance of the hits that told you whether you were probably navigating that line down the middle appropriately. But the other thing I should say, before I go off that slide, was the input that I had from other people. So I would have tradies who'd phone me, probably to berate me, and leave a message on my voicemail, but I would pick up the phone and they would be taken aback. And then we would have a really interesting conversation, and I would find out what worried them, what questions they had, what their understanding was, because that's how you find out how the misinformation is really translating out there. And that really informed how I engaged with community, because I was hearing from community. I was answering questions that had come from community in the public domain. But that also gave me a rich understanding that I thought I could then bring back to help the whole situation when it came to the kind of complexities of the inquiry and how we would draw such disparate views together. So I'm just going to briefly recap on this traversing disciplines notion. And when I first started, we were talking about inter, cross, maybe multidisciplinary. That was the language used at the time, last century. And we probably saw more of it in public health than in other places, because we did have clinicians working with biostatisticians and others in research and so on. But the focus was, that it's good practice to have different disciplines come together because they've all got something else to contribute. Then we started using more language around mixed methods, and it wasn't just having a qualitative and a quantitative researcher working together. It was people acquiring both those skills so that they at least had enough knowledge that they really knew how to bring people in to do more advanced qualitative work if they were fundamentally quantitative, but they knew enough about qualitative research. And I really think in public health that strengthened where we were going. In public health and clinical health, we talk about interprofessional, so where the other disciplines come together, even as part of their training, to really build skills where allied health people know how to work with medical doctors and so on. But then it got a bit more interesting, talking about trans or metadisciplinary or integrated studies. And now we're talking about something else. We're talking about approaching things in a way where the magic that happens when you have these people working together isn't just the sum of the parts. It's something else. You have different insights when you have people who bring different skill sets, different perspectives, different language even together, that you work together in a way that that creates new opportunities for translation of your research. And that's very much where we are in health, thinking now about systems thinking as well. You can't look at the health system, health in a system, which involves social structures, economic structures, cultural perspectives. It's all a complex system. So you do need all those disciplines working together to help map the system, let alone know how to work with the system so that you create healthy systems for our community. They can make healthy decisions, they're enabled, they can afford healthy choices. And a similar situation applies whole of government, because I hadn't realised how much the kind of culture, language reinforces government departments. People do move between government departments, but some people stay there as career people. And so it's quite a different world when you look at how people think or what they see beyond their department, and whether they're central, whether they're in the PM's office or they're in a very specific domain within a department. So there was this whole learning curve. Even though I'd worked in government before, I'd never really kind of understood it because I hadn't had the opportunity to look at something from a whole of government perspective. So this is my pictorial analogy. You've got some areas where you've actually got some bridges between existing disciplines. People have been working together for a long time. Other areas that are still very isolated. And if you think about how you work across disciplines, you know, there's the helicopter view, the kind of multidisciplinary, you draw on all the different areas. There's bridging, so actually trying to create a space on the bridge where you're bringing the best together, and it's not just getting it out of those disciplines, but also, as I said, creating that kind of space where you might have new insights because you brought this together. And then there's a space where I probably spent some of my early years kind of trying not to fall down the gap between disciplines and actually be nowhere, not be owned by anyone, not be fully understood by anyone, and maybe not be a specialist anywhere because you're too seen as a generalist. You're a bit of this, you're a bit of that. And so that's a risk in this space, but it's one we have to be very aware of. So the difference between working together and shared conceptual frameworks, I think, is something important to think about. It does come with barriers, including language or enablers, depending on how you see it. It brings together different knowledge systems. Now, clearly working with people in Indigenous communities, we're very aware of that, but that equally holds in some other areas in more subtle ways that perhaps people aren't cognizant of at the time. Reinforced by cultural frameworks, the politics. I talked about the political nature of my own work, which I hadn't really seen before COVID in this kind of way. And ultimately, it's about having insight and awareness and looking out for these things as being players in the way that we do our work. But ultimately, you can make that work if you respect different knowledge systems, different cultures, and the idea of working together. That has to come with a commitment. So integration of insights, to me, is the kind of ultimate aim. And really, that's what we were trying to do in the inquiry. We weren't going to come up with recommendations or actions that were going to work if they didn't reflect voices we'd heard from a number of places, but really distill it down to actionable insights that were going to make a difference in our preparation and response to future pandemics. So what we learnt from the pandemic were some key things. These were the general ones we took away as a panel. It was all about fixing the next pandemic, not the last, because a lot of people got caught in the last. You have to understand the last, but it was very forward focused and trying to understand what we could do differently next time. The next pandemic won't be unprecedented. That was such an overused term. Everyone got quite anxious when people kept using it. And we just said that you will not get away with that. Even if it's 50 years' time before anything else majorly happens, there'll be people who remember. And there will be records of this pandemic that mean you can't claim that. And it does a disservice to Australian people if we don't learn from the mistakes, if we don't look at the big picture, the economic, social and human costs, and the fact that these will probably still be impacting us, maybe even in 50 years' time, but that many individual impacts from the pandemic still go on today. And the tail was something that wasn't really fully understood and still isn't. And that's something we were very cognizant of. So those community members and sectors that are scarred more than most still live with that. But in that, it's also shifted expectations of government and this whole notion of national coordination in a crisis. People are less likely to comply as a result of that with prolonged restrictions in future. It's not as bad as places like the USA, I think, but it's a reality. So it's shifted the fabric of our society in a way. And as part of this from a health perspective, there's also the impact, particularly on the health workforce, been a lot of turnover, people who didn't have leave for 3 years, who were at the front line, but also being beaten up by people who just hated hearing that their loved one had passed away and they couldn't be with them. That they were offering vaccination, when it was an untested injection that shouldn't be given to anybody, whatever. So they had a really difficult time. But losing those people from the workforce actually means that our workforce was less prepared by the end of the pandemic than it was at the start. And while we had agility, people often use the word building the airplane while flying it. Our ex-dean at Deakin used to use that expression quite a lot as well. But it's unsustainable, and you should never go into a pandemic expecting to build the airplane while you fly. You'll have to do bits of that because every pandemic will be different, but you shouldn't go in without the basic dial-up infrastructure to support a pandemic response. So these were just some things from my particular perspective as the epidemiologist. Firstly, the precautionary principle. It's absolutely the way we should go into pandemics. It is not even just a right, it's kind of an obligation to act without waiting for evidence. You've got a new virus, you don't know how it transmits, you're not quite sure who's going to be most impacted in the community. You put in place basic hygiene methods on day one. They're unlikely to do harm, but they are likely to perhaps, help you buy time as you start to understand the pathogen enough to then be more specific in the way you approach your interventions. But what we saw was the precautionary principle put in place, and it didn't last for 3 months. It actually lasted for 2 years in some places. And there wasn't a commitment to gathering data to know whether they were actually doing what we thought. I'll come back to that later because I think the sort of cycle about evidence-based policy was something that we lost sight of. And, people started off on a sprint, but we had to put that extra investment in early on to be building some of that infrastructure, including evidence, that would have perhaps changed the way we approached the next year and a half before we opened up again. And the pandemic road we took was different. We had the ability, particularly with the cohesion of National Cabinet at the start, one of the great decisions that was actually made, bipartisan support for Scott Morrison's quick response to put COAG aside and actually pull together National Cabinet with the First Ministers of every jurisdiction in the room, and the way they worked together to lock down Australia, to close our international borders, was quite remarkable. And it did buy us a different opportunity, and few other countries achieved that, New Zealand, Singapore and a few others. But it meant that we were paving our own way. We could then, apart from some large outbreaks, still, the majority of Australians hadn't been infected by the SARS-CoV-2 virus by the time we were rolling out the vaccine rollout. Now, that was part of our challenge because people weren't then as motivated to be vaccinated. They hadn't seen what COVID could do, but at local community level, they were seeing that. We had Delta causing devastation, particularly in poorer neighbourhoods. But by the time we opened up and we did really experience community-wide transmission right across the country, we were not an immunologically naive population, and it did make a difference to the number of people that ended up in hospital. Our hospital systems could support people. They were never overwhelmed to the point where their care or care of other people was compromised. But you have to collect your own data. So when we were opening up, we were still using data from overseas, which are based on the effectiveness of real-world data on the effectiveness of vaccines when you open up and stop your lockdowns, on people that had had both infection and vaccination in the main. And we didn't have that. But we weren't even going in and looking in detail in our Delta outbreaks to see where we might have had that, what that meant and what that might mean for the Australian population. So we went our own path. My language around this was we've got to pave them with our own data, or else you're not necessarily having the right evidence. It's got to be the evidence you need for your decisions. There's a lot about creating and using evidence I won't go into here, but all of these things would have mattered to the way that we communicated about the effectiveness, the way we thought about our responses, the way we managed some of the division in the community. It's great to have evidence-based opinion and then that to lead to advocacy. So we had that when we were supporting overseas-born communities where we saw higher death rates. We could have done that earlier if we'd already also realised that they had the lowest vaccination uptake rates, and making sure there was tailored messaging, but also, importantly, support and working with communities to understand barriers. But what we actually saw was evidence forgotten by a lot of people. There are a lot of people out there with opinions, even people who kind of work as experts in data fields weren't always referring to the data. They just had an opinion, like you should stay in lockdown or you can't come out of lockdown while you've got any cases, because the health department can't cope, or no more than 10 cases. And all this didn't make sense because it didn't relate to what we were actually achieving in contact tracing and all the other things. And so moving into advocacy when it's not linked to evidence is really problematic. And this expression was actually by one of our most senior scientists, but talked about people confused. They didn't understand the difference in the end between evidence, opinion and advocacy. And I've already mentioned this, it was suddenly all these people appearing, and that does add to the confusion where you've got people presenting themselves as something that they don't actually necessarily have direct expertise in. So the way we structured the inquiry was around, obviously, a lot of input. So we had public submissions, came from organisations, but also lots of individuals, people right across the community, unions, government, business, community organisations. And from that, we also had 27 roundtables in areas where we felt we didn't really have a clear way forward, where we'd had different views from people, or they were talking more about what hadn't worked and we wanted to pull them together and find out what had. Those roundtable summaries are still available on the inquiry website and were really interesting. We then also commissioned some qualitative and quantitative work, which was important. I'll just touch on that briefly in a second. And we had ongoing conversations as we went, because we were working across government departments. We wanted to capture all the facts, so we had to test we had the facts right. But in the process, you kind of, in those conversations, you could socialise some of the things that were emerging out of the consultation that might be, aligned with the ways we were going ahead. And so it was an intervention in itself, really, to have these ongoing conversations through the inquiry process over the year. So the final report, large, but at the same time, importantly, we produced a summary report that we wanted to get out to people and to be readable. We went down the path of easy read reports, which is, I don't know if you know easy read reports, but they are very demanding in terms of so for people who are cognitively impaired, and so it is really working across neurodiverse communities in a way that almost defies logic on how you can explain National Cabinet, for example, in less than a page. And so that was another exercise, actually, in really trying to be committed to taking this and putting it into something that would be accessible without reaching a point where it wasn't saying anything of use. We ended up with 9 key recommendations built around shaping the future pandemic response. So this was very high level. It was basically saying a playbook for the next round of decision makers whenever the next major crisis hits, so they could then look at this and see how it translated to whatever's available in that time and age, in terms of technology and so on. But beneath that, for the current government or whoever is in place in a month's time, there were 19 immediate actions that we felt were needed to really do some of the basic work to prepare us for the next pandemic, assuming that it could potentially be on us in a few years and not 50. And then some others that were less urgent. I think we had 7 of those. But they were organised around these 9 pillars, and this is something that we cared about. This is one of the first conversations we had as a panel. We felt that it had to be a whole of government response to a lot of this was sort of led by health, and health wasn't actually geared up to do a lot of it. And then there was flow-on effects, and other departments were doing things they thought needed to be done, or because they're reactive. And what you really need is to recognise that actually, if you want someone to not go to work when they're sick, that's not a health decision. That's about what you can put in place to reassure that person that even if they don't have sick leave, they will still have an income if they test positive and have to stay at home. You have to think about stay-at-home orders for people who can't work from home and what that means, for their income as well. So there's this whole suite of things that you have to think about from a whole of government level. But the other part of it was that actually looking at an issue in silo meant that you didn't come up with all the best interplays that might happen. And there were some really wonderful things that happened in this. There were some really great innovations put in place. But we found that some of those was because someone who was very senior, maybe at secretary level, had actually previously been in one department, moved across to another department, and had an understanding of both departments that allowed them to see an opportunity. How to bring in Services Australia or link data or get money out. What's the fastest way to get money out into Emma's pocket if she tests positive or whatever. JobKeeper was held up as a real model of something that they got up incredibly quickly. And they could use new systems that were put in place to push that money out. So it was this sort of sense that you had to look at that higher level and then work out how departments work together to get there. So these were the pillars that we came up with: minimising harm, the need for planning and preparedness, leadership and coordination. But then some of the other things I've already touched on: evidence and evaluation, putting things in place that allow you to be agile, being able to dial up things, even if it's the ethics approval process for emergency research. You push out the funds. They had priority research areas. People waited 6 months for ethics approval because they were using peacetime approaches that were very, very, very low risk tolerance. It should make sense in a pandemic. Relationships, not relying on those organically, but to actually build the infrastructure to support those and make sure you've got those in place. Equity was such a key area because of the differential impacts in relation to exposure, likelihood of serious disease if infected, and the impacts of the interventions. Gathering the data to even see that wasn't possible at the start of the pandemic, and even in the vaccine rollout, it took a long time before we're getting breakdown of data. Some of the areas, particularly working with Indigenous communities, there's been a longer tradition of working with community groups, with actually looking at data in more sophisticated ways. They, in some ways, were better served because there was a history, whereas other groups, including older Australians, for example, and people with disability, were less well served. Communication and trust were kind of universal issues, and all the other things were impacting on those as well. And in fact, it was one of our kind of truisms. We realised as we worked through that failure in any of those pillars could undermine trust. And to build trust, you had to work on all those pillars. So I'm not going to go through these here, and they're too small for you to read. This is really just luring you into reading the summary report if you haven't already. But just as an example, you know, talking about minimising harm, the guiding recommendation is decision-making processes in a pandemic need to fully account for the broader health, economic, social impacts of decisions and the changing level and nature of risks to inform escalation and de-escalation. No one had ever thought about de-escalation of the response to minimise harm. And so it is about understanding risk, balancing risk, but also understanding how risk is distributed across our communities. Sadly, the people who are often most impacted by interventions weren't the people who would have been most impacted by disease, for example, directly impacted. So there's a whole lot of things going on that actually made this very complex, and a lot of it didn't start to really get, the nuance didn't get understood till quite late in the piece. So the qualitative research, I'm just going to kind of whiz through these, but we had prioritised the groups that were identified as priority groups in the pandemic, the people often most impacted or who'd fallen through cracks when it came to data, homeless people, for example. International students didn't have access to most of the intervention supports because you could be in Australia, you could be stuck in Australia, but that didn't actually give you any rights to JobKeeper, even though you relied on casual work in restaurants in the main, and they were closed. And we used both, different companies did the qualitative and quantitative work. They weren't mixed method, unfortunately, but they focused on similar structured groups to overrepresent these particular people. And so what the key takeouts from this were that overwhelmingly it's a negative experience. No one really goes through a pandemic and says, well, that's good, I feel better for that. You know, it's by definition a problem, but there were certainly people who travelled through it a lot better than others. And so that way it impacted people physically, mentally, socially, relational, educational, developmental and or economic wellbeing, all impacted. We also heard about the perceptions and experiences of the government response, and again, how that varied across groups. But people were overall increasingly frustrated, distressed and angry. Border communities, people who lived and worked across a river that happened to be a state border, people who couldn't get back into Australia when they had someone dying in Australia, or could get back into Australia and be held in quarantine a kilometre from the hospital where someone was dying and died. So there's so much going on in this space, and personal stories matter because that's actually how these things translate. Pandemic information and measures often didn't meet the needs of Australia's heterogeneous population. And a lot of groups, whether it was Indigenous communities or schools, would actually take the information and then structure it in a way where they could feed it out to their communities because people were coming to them for the information. And there are ways we could do that, which isn't relying on those people to find the resources to do that themselves. It's actually pushing money out through community engaged groups, but it's also preparing information in kind of bundles that actually translate into a process more easily, where they can be adapted for communities to make their own and to make that a really viable communication pathway. So over time, the expectation of the greater federal government oversight of the pandemic was also undermined. We went from that very cohesive start downhill pretty quickly. By middle 2020, it was already seen that states were competing or arguing with each other, and not long after, we had the federal government coming in and clearly not being able to marshal everyone together. There was this real sense that we were a federation again. We weren't operating as a nation. And the negative experience during the pandemic disrupted these other factors. And I referred to this earlier, where people were talking about it in a way that led these researchers to describe it as, this sort of fundamental shift in the social fabric of Australia. The quantitative research actually really well aligned with this in terms of what we were finding. So it was a relatively short survey, but they were able to compare it with their own survey results from earlier stages of the pandemic, so they could also track changes over time, and that's in their report. But this table shows the areas where people found an overall net negative effect. So up the top, mental health, more than 50% of people felt a negative impact overall on their mental health. What's interesting is some people didn't do too badly in the employment situation. There were more jobs created. Some people actually got a higher income on JobKeeper than they would have for their paid work. So that was a positive, but the majority of people still saw it as a negative. More than a third, not the majority, more than a third actually saw it as a negative. But trust in science was the one where the net positive was actually higher than the people who described it as a net negative. And I think that was because people suddenly thought science is important in my day-to-day life in ways they hadn't before. Not that we got this communication right all the time. This was talking about how they would sit with future government directions, whether they would, in the darkest colour, definitely comply. And for most, more than 50% would. Not many more than 50% for some, like mask wearing, but the sense was they would. And if you put the probably would in there as well, you would still have a good public response. The Australian public were exceptional, I think, and they were doing things that I don't even think we should have asked them to do. I don't think you should ask people to wear a mask every time they walk out the front door of their house or in a pasture on their farm on their own, and that was sort of this expectation that people only followed very simple rules. I think people did an extraordinary job. But what we heard was, to do it next time, they'd want the evidence. They'd want to know why they were being asked. They want to be sure that there was good evidence behind it that said it worked. They'd want to know what evidence would be tracked and how they would know when they would be able to stop doing this. So they were very reasonable, I thought, by saying, okay, that was a bit weird, having to be in lockdown when we had 4 weeks with no cases in Victoria. No one else in the world could understand that. We probably wouldn't do that again, because if there's this demand for the evidence and there's a more transparent process of the link between evidence and policy, evidence and pandemic rules, then you'd probably get a finer balance and be asking people more specific things that they need to do for more specific times. And I think that would keep people on board from what we heard. I'm not going to spend a lot of time on communication and in particular trust and its relationship with vaccine misinformation, because that's a talk unto itself. But what we did see was a whole lot of areas where work should be done about how you work with community. It's not even about targeted information and thinking we know what teenagers want to hear or when they want to hear it. It's how it translates into local community, but also what they see as relevant. A lot of our overseas born communities had stronger communication links to their home countries. So we didn't even have control over what they were listening to. They were being fed information through their community and family networks. So trust, comes off the back of all of that. And in relation to information, there were a lot of information gaps. That actually was a real opportunity for people who were either deliberately or not spreading misinformation. And so there was so much in that space, including people who thought they were doing the right thing. That's probably what frustrated me the most, was people who who thought they knew something and had to get it out there, but they were wrong and didn't know that they were wrong or didn't bother to check whether they were right. And that negatively impacted on people's right to make an informed choice over important things like whether to get vaccinated, because they were actually misinformation. You know, it works against informed consent, despite the fact that most misinformation people are claiming out there that, you know, the government was the driver of people not having the right to informed consent. So there's lots of data we've included in the inquiry reports as well, but looking at, you know, vaccine uptake and how that's spread across the years as we move away from the primary course into subsequent periods. This is people who are 65 and over. It's dropped away probably too much in those groups. They still would benefit from boosters. So there is this consequence of the lack of trust. The data on the right show relationship between vaccine uptake and the deaths reported, because that sort of the vaccine uptake also tracks with the waves of the pandemic. But what we did find, and this was backed up sadly by deaths data as well, that the lower rates of vaccination uptake in non-English speaking communities was a challenge for those communities. There were high levels of social disadvantage, but that coincided with the kinds of work that put them at risk. And we looked at infection risk with Barwon Health and did some work on this back in the early days. This was 2020 data, but it was particularly the link to casual work, and that changed people's fundamental exposure. Exposed through work suddenly means something else if you work in 5 different workplaces in a day, if you're a cleaner and moving across sites. It also influences whether you can test, whether your symptoms are likely to be reported, the impacts that has on income and your work security. If you were laid off because you had to furlough for 2 weeks because you were found to be positive, you're well enough to work, then what does that mean if they fill the gap and someone else does that work? You know, will you have a job to come back to? Linked workplaces was the problem, because not only were people working across places, but if they became infected, they would infect across places. And we saw that happen in the aged care. So people who were casual workers as carers in aged care, or even the general practitioners, would actually work across a number of facilities. And the second wave in Victoria was characterised and largely driven by aged care outbreaks and people cycling the virus across premises. And then this notion of casual work being a problem, but actually we grew casual work. We had more cleaners employed, particularly in the early stages of the pandemic, to keep public spaces and hospitals clean. And of course we had hotels quarantine, they had to be kept clean, and we also had the security guards. So these all were areas where our overseas born population tended to be overrepresented, and that altered their risk. And of course, they impact different parts of policy. There was the economic policy to support people who couldn't work either on a temporary or ongoing basis. There were shared responsibilities, the aged care facilities regulated through the Australian Government, but some facilities are owned by state government here in Victoria, a minority. And then there was a big argy-bargy over who was responsible. But of course, the federal government, while it regulates, doesn't have an operational arm. It doesn't have people that can send out to aged care facilities, and state health departments run the public health operational response. But there was no plan about how you bring those things together in a pandemic. So we had very senior ministers on the phone trying to ring people and get nurses out of private hospitals to get to aged care, and things that should have been thought about in advance. And of course, if you talk about hotel quarantine security, not only had it not been thought about, physical quarantine hadn't been thought about. When asked in the inquiry in Victoria, they were told that no one was responsible, or they'd all forgotten, or whatever it was. But yeah, clearly work to be done. So this is kind of my flowchart of evidence-based policy and the things you need to think about in a pandemic. You end up having, say no data to start, you operationalise the precautionary principle and put your first pandemic orders out. But then you basically have to follow this through. You've got to measure risk, communicate risk to community as part of your first communication, implement some basic measures, evaluate whether they're working and what that tells you about the problem you have and your control measures. This all starts to generate data you feed into modelling, to do forecasting, to update your pandemic orders. Is it doing what you hope it does? Your intended consequences? Is it effective? Communication has to be a key part of this. What you learn from your evaluation should be feeding into communication. what's the cost of this? Have you really thought through and understood how it will impact individuals in community and all individuals, not just a sort of an average that doesn't actually exist at the community level? And are there any specific unintended consequences? So community input is really important, not just to get information out, but obviously to make wise decisions at the policy level, because you actually understand community. And if you've got a problem to solve, don't sit there and decide how to solve it. So I'm going to use an example in Victoria. We had the curfews, and that was one of the things that made the national kind of agenda, because it became quite a controversial area to put curfews in place. And so we had a curfew that started at 9 o'clock, and the concern of those of us working in infectious diseases was all you were doing was compressing the time where people could do the things that they had to do, like go to supermarkets or go to a health clinic or whatever. They were now more likely to meet other people because they had less time to do it. So moving it from 8 out to 9 o'clock, then the government's view was less people will be mobile, but of course, if you have to be out, you have to be out. But the comment that was made about that from the First Minister here in Victoria was, so what? People just have to finish their jogging an hour earlier. As if that's what people are going out to do, their 1 hour of exercise. It was actually grocery shopping or going to the one person they're allowed to go to, their partner or their mother, or be able to get there after work and maybe get home again. So it was this disconnect between who was making decisions and the impacts of those decisions. You need community input. So then you have to revise, be open to revising what you're doing to tailor it as you're learning on the fly, evaluate again, communicate again. And doing that means you're starting to generate the data. That then means you're no longer relying on the precautionary principle, you're actually working on an evidence-based process. But it's only going to work if you've got consultation from the start. And Victoria's legislation was changed to include, as a first step, building consultation frameworks within the new pandemic legislation. And the consultations are mentioned up front, but it's the First Minister who decides who they should consult with. And I actually think the first step should be to bring in a consultation advisory group to help them understand who is impacted and who they should be talking to. Because the First Minister won't necessarily know who, well, they don't know, and who they need to go to and who should have the input. And of course, it's not just one policy, it's many policies. And that's the challenge, is how you're doing this in a kind of a systematic way with multiple policies, you know, operating within departments, between departments and across departments. So thinking about this from a systems point of view and that sort of notion of how you bring it all together, I have a PhD student along with Stefan and Anna. We're supervising Matthew Bush, who's doing extraordinary work looking at the quarantine pathways. Again, I don't expect you to be able to see the detail here, but this is the map he's pulled together, one tiny part of his PhD, but actually mapping the way people came into quarantine and exited. And those purple circles you see are the relevant policy. And those policies aren't from the health department. They're from all over the place. And so some of them are not even kind of aware of each other, and no one's looking across policies to see that how they work and whether they are aligned and whether there are gaps in policy. And of course there were. We found out that there was sort of nothing, no one thinking about the safety and therefore the public security based on how people got from the airport to the hotels, and a whole range of things where there were gaps. So even starting to map these complexities and how they relate to policy is really critical work, and great to see Matthew doing this work. And this was really picked up by the inquiry because no one else has been doing this work overseas, let alone here in Australia. The other thing we heard a lot of talk about was just this question about, should we focus on the economy or should we focus on health? And of course, a lot of people said, well, if you have health, the economy will follow, you can fix that later. Or, you know, other people just said it's ridiculous, you know, if you, poor economy is going to impact health anyway. But it is, it's all part of a system, and it wasn't ever or, either or. It was always trying to do things in a balanced way that minimised impacts for maximum benefit. But sometimes if the impact was on the economy and that was unacceptable, you might have to moderate the maximum benefit in terms of case numbers if your hospitals could still cope, for example. Hard decisions, terrible decisions, but nonetheless the decisions we have to be able to make. So the summary report is written by pillar, and that's what we wanted to do, was to keep it at that kind of high level so that people would come at these issues under these broad categories of concern or of focus, like equity or minimising harm. And we were great. It was great to hear some people, and that particular quote I think came anonymously out of the Federal Health Department, where they'd been very anxious about this. They'd only ever seen what we had written as the documentation of what had happened, and they didn't know what we were going to produce. But they said, great read. Someone else just said, what kind of report has no lockdown chapter? Of course, lockdown is pretty much in every chapter. It's about leadership, it's about equity, it's about minimising harm, all the areas, a lot of lessons to be learned. And someone else very specifically said there's no mention of infection protection and control. But again, that's about training and capability building and so on. And it's in the main report, but, you know, people respond differently. But importantly, what's in detail in the summary, which isn't repeated in the main report, but is our recommendations for Australia's permanent CDC. And I'm sure we'll come back to that in our discussion, but that was one of the key areas where there were specific tasks, things we didn't have. And we heard in the inquiry, and we've heard since, particularly from the Coalition, a sense of we don't need it. We do better than most other OECD countries, and they all have CDCs. Well, they don't. The majority of OECD countries don't have a CDC. But it's very clear in our inquiry, even from state-level health departments who people perceive as being pushback on the CDC because they don't want to be told what to do. They don't want a national body. They were recognising the value in having a centralised focus where we could bring together expertise at the national level to support each of the states and to have a coordinated response and do the work states didn't have the time to do, or coordinate the work across state health departments. So the landing of all of this happened in October last year, and it, I must say, was better than I thought. I'd sort of gone into that thinking, you know, I always knew we weren't going to please everybody, but I'm pretty sure I haven't pleased anybody now, you know, because everybody had particular views that kind of all went over there, and you were trying to have it in the middle and come back to something that was going to be a practical takeaway for the government. But in fact, it overall was balanced. Now, by balanced, I mean there were extreme views, but we had extreme views in both directions. So we thought that was pretty good. And even in the Australian newspaper, we had both extremes. And I think that's probably a good representation of diversity rather than imbalance in the report. So I think this might have been Bronwyn Bishop, but, you know, blame Morrison. It was just seeing they just expect it to be an attack on the Coalition, and they probably didn't even read the report. They'd already written their punchline. Others said, ooh, didn't work for Albanese. He was trying to protect the states. That didn't happen. You know, the states got blasted. And no lockdowns chapter, of course, came up. Idiotic and out of touch. Apparently that's how he slammed the government. That's Sky News again. So, you know, quite fascinating. Worst place than in 2020. So they picked on that particular theme. Mental health impacts, glad they picked up on that. That's one of the areas that was such a big one that's part of the tale, along with long COVID. Broke trust was the other big area that we did want to come out. And interestingly, Nick Coatsworth and also Brett Sutton came out immediately after the report and reflecting on some of the things that they did as part of their roles around whether it was vaccines and how that was communicated, or more broadly in Victoria, lockdowns and so on for Brett, where they kind of owned it and said we'd do it differently next time. And I thought that was such an important part of identifying the communication shortcomings, but also the first step in trying to build and rebuild trust. Someone said it deserved more than bureaucratic jargon, which made me think, I've learnt the language of government. I didn't. I know. You know, we went to lunch at the end of this. You know, with the broader team, brought people back who'd moved back to departments or across the government, and one young guy there, also Bennett, unrelated. But I just said I was so impressed with the effort they put into trying to understand the complexities of the data and how we used it and why people kind of got things wrong and whatever. I said it was so impressive because they'd all sit there and concentrate, and they learned so much. And apparently, First Secretary of the Prime Minister's Office had said to the person who led our task force, when he called her in and asked her whether she would do the work, he said, Catherine Bennett's on the panel, you're going to learn a lot about epidemiology. So I was saying this to him, and he said, we were all really impressed about how much you understood about government, how much you listened to us, and trying to find, so all of that, what does that mean? What do we take from that? You know, what's government responsibility? What do we learn? So, a lovely letter from Glyn and from the Prime Minister shortly after that sort of recognised the magnitude of the work. But why I put them up here is Glyn talked about particularly acknowledging the breadth of the stakeholders that we'd engaged with and the importance of ensuring that wide range of voices were heard. And Prime Minister likewise talked about the panel being able to distill a wide range of views and, distill those into a clear pathway forward was really, really critical. So I do think it kind of wound up being the ultimate bit of my career story and bringing all those things I'd learnt over time together in something that I hope will fundamentally make a difference. They did on the day they put this report out, put the press release out where they committed $251 million to the new CDC. But of course, that now sits, we're still waiting for the formal response from government to this. They've had a task force working on this ever since we submitted the report. That's got bigger at different times, which is encouraging. So I think we'll still hear something depending on the outcome of the election. So as they say, vote well and vote often. This isn't everybody I've ever worked with, but these are people I've worked with in kind of recent times, just to show the wonderful mix of disciplines that I continue to work with. A lot of this was sort of working around COVID, but not all of it. There were other things that were going on in the meantime. Lots of other clinicians, a lot of other great colleagues I work with. But just to give you a bit of a sense of how having that kind of career and that commitment creates such a rich range of collaborations. And as Emma and I were talking about before today, this is increasingly an expectation in other discipline areas that they start to work more in a multidisciplinary space. As I said, public health has been naturally doing it for a very long time, and a lot of the sociology and archaeology areas as well. But thoroughly recommend it.
Wow. Amazing.
Any other politics?
You're not the first to ask. You're not the first to ask, but it is.
It's a different world, different language.
But I think you always learn, that people go into politics for very different reasons.
Yeah.
And I have the most fundamental respect for the people that go in for the right reasons. But yes, no, people have asked me that throughout my life, actually, and it's quite interesting. And I wonder whether that's because of the consultation work and the engagement and that commitment to translation. And I think that speaks highly of politics if people think they're the kinds of skills that we should bring to politics. But no.
Wow, that was so exciting. And actually that list of people and when you were speaking, it reminded me that Catherine really is the patron saint of the Science and Society Network.
I should point out that, a few of those are Science and Society projects.
That's right. A lot of people in the social sciences have benefited from all of those, many projects actually that Catherine's been involved with, and has been involved in seminars and before. So it really is a kind of bringing it all together moment. So I've got a bunch of questions, and I'm sure there's a lot of questions as well. I might just start with that. I loved your the narrative that you started with of your career trajectory, and it's so interesting how you've now returned to epidemiology, which was your first degree, or returned to microbiology, I should say. And infectious disease kind of was there at the start, and now it was out of focus for a while, and then
it wasn't long out of focus, I suppose. I think that's been the interesting thing. As soon as I came back to university, in fact, in my MAE, so I'd only had the 2 years working on the provenancing project. The MAE was very much focused on communicable disease, and then came back to Melbourne University with a focus on communicable disease epidemiology, but then they found the skeletons in the closet, quite literally, and so it sort of opened that up again. So I worked on both those projects for the university, and so I've been fascinated by the way they've woven their way through life. In fact, the only time the two of them really came very specifically together over one task, though, was in East Timor. So after the conflict, they put a call out, and so through both my networks, there was a call out for, sadly, for forensic or physical anthropologists to work on the mass graves, and there was a call out from the Communicable Disease Network for people to go in and re-establish infectious disease surveillance. And I thought, I hadn't really thought about it, but the one place they came together was in this time of crisis, which was sort of which was a sad thing to see. But actually, through my career, they've managed to kind of weave their way, and it's been great to kind of be able to use those skills and engage with community, you know, on an ongoing basis. So, yeah.
Yeah. Have we got any questions in the room? Yes.
It seems that in the last pandemic, the emphasis was on minimizing the social cost at the expense of economic cost. For example, many negative externalities, such as all the individuals and businesses who did not benefit from government handouts, and also all the future taxpayers due to the huge budget deficit. But that seems to be the problem in every response to whether it's economic problem or environmental problem, emphasizing the short-term benefit at the expense of the long-term benefit.
Yeah, and I just for the benefit, I think, of online, because they won't have heard the question on the machine.
I think that, no, there's a
There's a good pickup? Okay, that's great.
Someone will,
So I wouldn't be as articulate.
yeah.
I think that's right. I think two things you touched on there. One was whether it was societal or even just a narrow focus on health specifically. And there was a lot of criticism of that at the time. I think short term you can do it. I think long term it's a problem. And as you rightly point out, there is a long term consequence even of some shorter term responses. But we had a well exercised emergency response process in Australia. We respond quite well. That's not always great, but it's getting better. Bushfires and floods in particular, two areas. And that is built in. It's built in around all the kind of supports that are put in place, government emergency responses, finance, the commitment to rebuilding communities, insurance, though that's getting more and more problematic these days. But it kind of, they know that it'll work out, but you've got to invest in the recovery. So we talked about the tail, and we also talked about the recovery and the implications for that. And that wasn't really talked about a lot. So it was all that sense of the precautionary principle, as I said, from the evidence point of view, but also this kind of response where we'll worry about all that later, but you're now 18 months into this and we're still worrying about it later, when the later was going to be enormous. And no state feels that more than Victoria, with the burden on taxpayers today and going into the future as we recover from that. So that's very much why we're saying it has to be whole of government. You have to look at those long-term consequences. Modelling shouldn't just be about how many cases will we have if we go this path or this path. It's saying, what is the balance between health, other societal impacts like not letting people be near their loved ones as they die, and a whole range of things around industry, business, supply chain, all the rest, which was such a big part of it. But just to say on that, I remember it was the Vice-Chancellor of Melbourne University, and a lot of people were in touch with me on LinkedIn. They started talking to me. So I did have people from all quarters. My LinkedIn messages were going out to boardrooms. So Qantas were using my LinkedIn messages every fortnight to kind of guide what they were discussing in their board meetings. The Chief Medical Officer told me that he relied on them a lot to know what was happening in Victoria, because I would summarise the outbreak information from a straight-up epidemiological point of view. So it was interesting sort of hearing about all their perspectives. But the one that really struck me from the VC from Melbourne was he put out a piece, because there was a concern also that health wasn't going to be universally a problem. It might overload the health system. But as I said, there was a disconnect between the people most at risk and the people we were asking the most of, including businesses. And so he started using the language of QALYs. And so the quality of life years lost, and balancing what the impact on a young person, say if it had really driven up suicide rates in teenagers, as opposed to someone dying 6 months earlier at the other end of their life because they contract COVID. You have to make hard decisions. We make them all the time in health policy in terms of what's listed on the PBA. So what medications, what devices, what aspects of medical support we'll provide. You have to do trade-offs all the time. but the population wasn't ready to have that conversation. So one of the things we also talk about is there has to be a readiness. We need to bring in the philosophers as well as human rights. And the Human Rights Commissioner's report came out just a couple of weeks ago, and we obviously talked a lot to them as well, but again, very aligned. But you need to be prepared in that way, because it's not always going to be straightforward. Or it's just simple, we'll only focus on case numbers and keep them as low as possible at any cost, if you haven't even thought about what those costs will be. So that was the big lesson from this. And that's the whole of government response that we keep emphasising. That's why it's really important. So thank you.
Yes.
There were a lot of conspiracy theories about the origin of COVID-19. Animal to human contact, or was it a biological leak from a laboratory? Has that been finalised?
I think the fascination in that is it won't be possible to know unless someone came forward and said, "I'm confessing, I spilt the Petri dish myself," and then we wouldn't know if they were telling the truth anyway. We will never know. But all the evidence, even at the time, despite the way emails have been taken out of context, and I've spoken to the virologists involved and virologists who'd worked at the laboratory just before this happened, Australian virologists, and also to COVID experts and people who were in Asia at the time. They actually had a conference just after this leak would have happened if it actually came from the laboratory. And their view was, we would know. If something happened, we would know. There would have been gossip. There would have been something about someone's demeanour. Someone important wouldn't have been in the room because they were being called out on phone calls. There was absolutely nothing to suggest anything was wrong in the weeks immediately following that within the community in Asia. And the people I know who'd been over in the labs, with collaborators, said, really well managed laboratory. It's not one that would work the way. And they had photos of the Wuhan laboratory where they said, there were bodies stacked up outside the back, and they just said it couldn't happen. Like, it's just ridiculous. It could not happen. So they were really grappling to pull things together. So the evidence that I've followed and the more recent evidence, the kind of pull it all together piece from the genomics suggests it came from wildlife, and maybe not just the Wuhan wet market, but certainly centred around Wuhan, and it was that crossover point that happened. And so there's no reason to say it had to have any other complexity, because it could well have crossed over from the wild population. They have the virus that would have been the ancestral virus in those populations. So anything else is just like could have possibly happened, but you don't have to go to that extent to explain that it happened.
So are we better prepared for the future now?
Well, yeah, I think it's one of the sad things about this pandemic is what it has done is changed our pandemic potential. So we had a soup of human influenza virus, and you're interested in this as well. And then we had avian influenza and other forms of influenza out there, and we worry about that spillover so that we have a pandemic flu. Now we have human coronavirus, SARS-CoV-2. And in fact, Omicron may have already been an example of this, where we had a new crossover event, but thankfully, while more infectious, it was less virulent. But that's bumping up into the animal populations that also carry related SARS-CoV-2 viruses. So both influenza and COVID now have a similar propensity to have a spillover event, and suddenly we have a big shift in the variants circulating. We no longer have the benefit of immunity, whether it's COVID or influenza, and we could see a pandemic. That said, when I first got into this area, I was told we were 20 years overdue for a pandemic. Now, pandemic was influenza. That's all they kind of really thought about. That's what our plans were actually written for. And that was, a long time ago. And while we had some starters in H1N1, and we started to see some outbreaks of that looked like a pandemic and was called a pandemic strain, it didn't take off. We had it in Australia and you didn't even really hear about it. So maybe the early detection work we're doing, and maybe the lessons learned, and maybe the thing we heard about overnight, which is multi-country sign-off on the draft pandemic agreement, which is includes sharing information on isolates that we're finding in community, doing that really detailed surveillance work, and that commitment to early reporting if there's a problem anywhere, will mean you might see the starter points, and there might be more of those now, but we might stop them turning into pandemics. Much easier to prevent a pandemic.
I think we should end on that positive note. And I'd just like to thank you so much for this talk and just for all your work. It's just unbelievable. And thank you.
Great communication and clarity. Thank you very much.
Thank you.
Thanks, everyone. And just before we log off, wanted to let everyone know about our next talk that's coming up, which is Professor Andy Lakoff from the University of Southern California, who'll be visiting us at Deakin. And it's actually, on the theme. Planning for the Wrong Pandemic is his new book. And Catherine, if you'd like to come along, I think you'd really I think it'd be super interesting. And then the other thing we'd like you all to put in your diaries is our flagship event for the year, which this year is called Doing Interdisciplinarity, 6 years of the Deakin Science and Society Network. So we have been running our signature small grants incubator scheme for early and mid-career researchers, and we're going to hear from some of our really amazing projects and see what they've done with the seed grants. Thank you all so much. See you next time. Have a happy Easter.
We're down.
In the stream and in the meeting, sorry.
Were there questions online?
No.
Actually, I had a question though, Catherine.
Yeah.
If you have the
Yeah.
time.
Yeah.
I don't know, wait, maybe I can ask it here because people are still sitting around. I was going to ask about, I've been thinking a lot about data-driven, evidence-based policy, which you talked about, and data-driven decision-making. And I was thinking